Hi, I'm Aurelia Ordóñez, and I'm going to talk about electrolyte and acid-base disturbances in patients with diabetes mellitus. Definition: acid-base disturbances. Diabetic ketoacidosis is characterized by the accumulations of acetoacetic. Ketoacidosis results when the rate at which hepatic ketoacid is generated exceeds peripheral utilization and the concentrations of ketoacid in the blood increases. Electrolyte disturbances are common in patients with diabetes and may be the result of an altered distribution and electrolytes relate to the hyperglycemia-induced osmotic fluid shift or of the total body deficit brought about vasosmotic diuresis. Complications from end organ injury and the therapies used in the management of diabetes may also contribute to electrolyte disturbances. Sodium. Increases in plasma glucose concentrations can lead to changes in plasma sodium concentration through several mechanisms. Elevations in glucose concentrations increase plasma tonicity, creating an osmotic driving force that favors the movement of water from the intracellular space to the extracellular space, thereby dilating the extracellular concentrations of sodium. The plasma sodium concentrations is usually low as a result of the osmotic flux of water. Increased or normal plasma sodium concentrations in the presence of hyperglycemia indicate a clinically significant deficit in total body water. Certain medications that are prescribed for the management of diabetes mellitus are also associated with hyponatremia. What is the treatment? The stabilization of hemodynamics with normal saline is the initial goal of fluid therapy in patients with a hyperglycemic crisis. During the course of care, a switch to more hypotonic fluids may be required for patients in whom a deficit in total body water has been determined. Isotonic saline infusion should be continued when the corrected plasma sodium concentrations is reduced. Acid-base disturbances.
Hello, in this video we're going to talk about diabetic ketoacidosis. This is an introduction and overview. It is important to know that diabetic ketoacidosis is a medical emergency, especially in type 1 diabetic patients. But it is known that it can also occur in type 2 diabetes. As the name suggests, it has to do with acidity. So there's increase in acidity in the blood, essentially. The signs and symptoms of diabetic ketoacidosis is nausea, vomiting, polyuria, polydipsia, weight loss, hyperventilation, known as Kussmaul's breathing. Now, diabetic ketoacidosis doesn't occur out of the blue. There's usually some triggers. And these triggers, these etiologies, it can be remembered as the 5 I's. The 5 I's are infection, intoxication, inappropriate withdrawal of insulin, infarction, and intercurrent illness. And these 5 triggers, they cause what we know as diabetic ketoacidosis. So let's go into the pathophysiology briefly. If you want to know more about the functions of insulin, watch a video I have on the fed state, which is under biochemistry. Anyways, the pancreas normally produces insulin. However, in diabetes type 1, there is an autoimmune attack on the B cells, which normally produce insulin. And therefore, insulin is not being produced anymore. So we have a decrease in insulin. Insulin is an important hormone, And because we have a decrease in insulin, this causes some problems. First, it means that gluconeogenesis is not inhibited. And so we get gluconeogenesis. We get more production of glucose. We also get increased glycogenolysis, and we get a decrease in glycolysis, all of which will result in more glucose in the blood. So we get hyperglycemia. Hyperglycemia results in glucose being peed out. So we get glucoseuria. Glucose draws water, so we get polyuria, and we also get dehydration as a result. Because we lose a lot of water and we are dehydrated, we get polydipsia. We get thirsty. It's also important to note that the decrease in insulin, the absence of insulin, means that fat breakdown occurs. It's a very important concept to understand. Fat breakdown occurs especially if the body is not receiving enough energy. So in periods of infection or feeling ill, the body will start breaking down the fat because glucose is not present and because glucose is not being taken up. Fats get broken down from adipose tissue to form free fatty acids, which then go to the liver and undergo ketogenesis to make more ketone bodies. It does this because the body needs some form of energy, some form of supply, because glucose is not working or because glucose is not present. With so much ketones being made, we get ketonemia. We get high ketones in the blood. And then subsequently, this means that we get ketonuria. We are peeing out ketones. And it's also important to know that ketones are acidic. Ketones are acids, and so they reduce the pH in the blood, but also they will reduce the pH in urine. This is the main pathophys we see in DKA. So if a person presents with the signs and symptoms we spoke of, a thorough history and examination needs to be done, and appropriate management needs to be performed, which includes checking the airways, checking breathing, and circulation. In circulation, IV access is important for a few reasons. First, to get bloods for investigation. It's also important here to get a base serum potassium level. After getting the bloods for investigation, administering IV fluids, saline, and also administration of insulin slowly is very important. Administration of insulin is important because we want the cells in the body to take up the glucose that is in the blood. While this is going on, investigations have to be performed. So ABG, which is arterial blood gas, is very important to measure the pH in the blood, and this needs to be done regularly. Bloods, as we mentioned, full blood count, EUCs for infections and also electrolyte abnormalities and dehydration. Urine analysis is important to check and monitor if there's glucose, ketones, and infections. ECG is performed to check for arrhythmias in case of potassium hyperkalemia or hypokalemia. So again, monitoring pH by doing regular arterial blood gas is important. And also it is important to monitor serum potassium levels. The reason it is important to measure serum potassium levels is insulin is being administered, because insulin will actually cause hypokalemia. If you get hypokalemia, you can actually trigger an arrhythmia. Sometimes calcium gluconate can be administered to protect the heart from the
To finish, hyperkalemic renal tubular acidosis. Hyperkalemic renal tubular acidosis, type 4 renal tubular acidosis, is a common condition among patients with diabetes and over nephropathy. This disease is characterized by disturbances in nephron function, which led to impaired renal excretion of hydrogen and potassium and result in hyperkalemia and a hyperchloremic normal gap acidosis. Continue with video.
Jessica here, and welcome to Critic. In this video, we'll go through not only the workup, but we'll focus a bit more on the treatment of hyperkalemia. Let's go, shall we? There are a couple of statements I made in previous videos on potassium that are helpful in remembering the workup to hyperkalemia. First, potassium resides predominantly inside of our cells. Second, our kidneys are great at retaining sodium and excreting potassium, so it's pretty rare to have hyperkalemia with normal renal function, but it does happen. And third, potassium shifts over the cellular membrane. Let's go through these quickly. The extracellular potassium, the one you measure in serum, is around 4.5 millimoles per liter, while the intracellular concentration is 30-fold, being around 150 millimoles per liter. So cracking open a cell like an egg will spill potassium and result in hyperkalemia. This is the case in hemolysis, rhabdomyolysis, excessive burns, tumor lysis syndrome, and crush trauma. If our kidneys are great at excreting potassium, it goes without saying that renal failure can result in hyperkalemia. If GFR falls, less potassium will be presented in urine. Potassium excretion is furthermore governed by the mineralocorticoid action of aldosterone and by tubular secretion. So a defect in either of these systems will cause hyperkalemia. Examples of aldosterone deficiency are drug-related, like ACE inhibitors, ARBs, and potassium-sparing diuretics like spironolactone, or an adrenal crisis, Addison's. Examples of impaired tubular secretion are some forms of renal tubular acidosis. If you've seen my video on hypokalemia, you know that potassium is prone to transcellular shifts. Flip the causes and you'll get the ones that result in hyperkalemia: acidosis, hyperthermia, note that I've never seen it in fever, and beta blockers. Now let's briefly touch upon pseudohyperkalemia. Just like in pseudohyponatremia, this is an erroneous measurement, so you're not to be worried about possible complications from hyperkalemia. The most common cause is prolonged tourniquet use while getting a venous sample. The tourniquet crushes the red blood cells that get into your sample. So the measurement is correct, high potassium, but it's only in your sample and not in the entire body. If you're unsure if this is the cause, get a new sample. Still unsure? Get an arterial sample. Pseudohyperkalemia is also seen in severe thrombocytosis and leukocytosis, as they cause in vitro release of potassium from inside of the cells. If your patient has hyperkalemia above 6.0, your immediate action is to monitor your patient and get an ECG stat, as hyperkalemia can cause heart blocks and ventricular fibrillation. Symptoms of hyperkalemia are not really specific, but include tingling sensations, muscle weakness, and paralysis. Symptoms or ECG abnormalities call for immediate cardiac monitoring, so admit to a cardiac or medium care, and immediate treatment, the first of which is the administration of calcium. The following steps of treatment should be on your mind. First, calcium. Calcium doesn't lower serum potassium levels, but it stabilizes the cellular membrane of the heart, decreasing excitability and thus decreasing the chance of cardiac arrest. It should be given to symptomatic patients, especially patients with ECG abnormalities like QRS widening or when the CT segment resembles a sign pattern. It should not be given to patients that use digoxin because it can lead to digitalis intoxication, or in combination with bicarbonate, as it may form depositions. So what do? When in doubt and to prevent delay, just administer calcium, as there is very little harm. Give 10 cc's of calcium gluconate 10%. This buys you about 30 minutes. If your patient is unstable, use calcium chloride, as this is more potent and can be administered faster, but it can cause severe thrombophlebitis. Second, insulin glucose solution. Remember that insulin causes a transcellular shift of potassium towards intracellular, so it's only a temporary solution. The glucose is added to prevent hypoglycemia. Typical dose is 10 units of insulin, the rapid kind like Actarapid or NovoRapid, combined with 50 cc's of 50% glucose. The onset of effect is around 20 to 30 minutes, and it will lower potassium with about 1 millimole per liter. Reduce the dose of insulin in patients with renal failure. Try 6. This step will buy you around 4 to 6 hours. So what do? Give it to all patients that are symptomatic or have ECG changes. If your patient is asymptomatic and without ECG abnormalities, give it if hyperkalemia is above 6.0 and you can't remove the cause within a few hours. Just like with calcium, there's not much you can do wrong in this case. Third, potassium binders, like sodium polystyrene sulfonate, Resonium, or calcium polystyrene sulfonate, Sorbisterate. These are insoluble molecules that bind potassium in the large intestine, preventing them from being absorbed. The effect starts after 2 to 4 hours and lasts for several hours, so it won't help you in the acute setting, but it's still considered very important and may be repeated. So what do? Always give a potassium binder. Just realize it's not the first step in treatment. I prefer a calcium preparation over the sodium one. This is because, as mentioned before, a lot of patients with hyperkalemia have impaired renal function, and administration of sodium could cause renal beta stimulation and thus tachycardia. The effect on potassium is immediate and lasts for about 2 to 4 hours. Consider the following treatments for specific conditions: dialysis in renal failure, diuretics and fluid overload in patients that still have urinary production, sodium bicarb for acidosis. Give 100 cc's of 8.4% solution. Thanks for watching, and don't forget to subscribe if you haven't already.
Okay, that is all. Thank you.